To introduce our next speaker is Dr. Amber Seidel, who is a postdoctoral fellow here at Purdue University. Amber?
Thank you. I get the opportunity to introduce Dr. Toni Miles, and I've had the great pleasure of getting to talk with her a little bit over her stay here. And I wanted to add a few things a bit that is not necessarily in the bio that you have provided, kind of to highlight some things. One of the things that I've learned a lot about Dr. Miles is that she has, I guess, many passions, but two that I've picked out on is one was her time as a fellow that she had. She went in her fellow position to Washington, D.C. to be an expert in gerontology, to provide them with expertise in aging. And she describes that she came home as a changed person in policy and understanding, and she gets to share a bit of that with us today, of course, with what she's learned. And she also shared some in this book. I had the great privilege of beginning to read it, and for those who haven't, it actually is it is a very fascinating book, and I've really enjoyed, even though policy is not my expertise either. I think that's one reason why I found it so interesting, is she didn't start as a policy expert, and that she can share that with us to help us understand how policy can inform us. The second drive I've learned about Dr. Miles is her current position as a director. And she shared with us how much she loves to wake up in the morning and to be a director of gerontology and to be able to work with individuals to solve problems and to help convince the world that we are all gerontologists and that everything that we do informs gerontology and can change the world. And so I would like to introduce and welcome Dr. Miles.
What an intro. How's it sound? Good? Okay, great. And I didn't pay her anything to. Anyway, I am very happy to be here. Like Cocos, this is my first time coming to Purdue. I'm a Northwestern alumni. And, you know, we've played you guys a few times in a few sports. Back when I was an undergrad, we were not very good. So it didn't quite matter. Anyway, so I'm in the nice position to be able to get the last word on both my fellow gerontologists. And I appreciate their shout out to me. Those of you who how many of you think you're going to be a scientist in the future and continue doing research? Okay. Being a scientist when you grow up. There you go. What you have to understand, if that is those two guys gave as much to me, or probably more, than I gave to them. You do not do this business alone. So, you know, shout out back to them. It was wonderful during the portion of my career that I got a chance to work with Cocos. I continue to work with Cocos on the Hispanic Epis. Actually, one of my graduate students has a paper coming out in the American Journal of Public Health next month. So it's if you have more than 7 babies or 7 pregnancies as a woman in young life, you will develop lower body disability at an accelerated rate in old age. And to be able to pull that out of current disease and everything else you would think, Doug's factors notwithstanding, is a major achievement. And so for a graduate student to do that, hey, graduate students rule, right? That's great. And I have a couple of upfront points before I start my own little diatribe. These two speakers gave you really good grounding in where we are with 2 populations and health disparities. And before I did the Health and Aging Policy Fellowship in D.C., I would have approached the world the way they did. I'm a physician, you know, did training in epidemiology, know a lot of anatomy, and I always saw the world in those ways. What I did not understand was policy. Policy to me was something that just got in the way of what I wanted to do. And now I understand what I did was from fall of 2008 through March of 2010, I worked for the Senate Finance Committee during the Affordable Care Act. Now, for those of you who don't recognize that, I was talking to a reporter from West Lafayette a couple of days ago, telling her all about that. And she said, well, when was this law passed? I said, This is Obamacare. Oh. So that's what I'm talking about for those of you who don't know. Okay, so I worked for Max Baucus, who's the chair of the Senate Finance Committee. I got to see it's like being in a slaughterhouse and watching sausage get made. It's thrilling because you know you're going to get some good eats at the end, but it's a stinky, sloppy, icky, vicious process. So a couple things I learned from that process. I'm going to comment on what they've said. So healthcare policy does not typically use race and ethnicity as eligibility criteria. So everything we do when we use those demographic markers do not filter up to the next level, which is policy. Just keep that in mind when you're designing your work and your questions. What they use is income. You know, if you're impoverished, that's how you get to be a dual eligible. Work history, that's how you get eligible for Social Security and other things. Gender, so if you're a pregnant woman, you can get on Medicaid. Those are the filters. And ultimately, everything we think about that will affect policy has to be able to make it to those kinds of filters. And a third thing I want to tell you is that access is driven by local factors. So it's nice to do the national comparison, but I think on the ground, what Doug does and what Kokos does absolutely has to be done. I love his ground acquisition model. This is like the football approach to healthcare inequities. And so what the Affordable Care Act does that will have an impact on what they've described to you is that it will require individual healthcare institutions to collect race, ethnicity, language, and disability status data at their institution. Let that settle in for a second. For the first time ever in American history, we'll be able to identify disparities that happen inside a hospital. That is revolutionary. So, having said that, I'm going to give you two reading assignments, 2 books. You got to go out, get together with 3 of your friends.
Will this be on the file?
Yes, absolutely. Okay, so 3 people get together. One of you buys my book. One of you buys a book by a woman named Isabel Wilkerson called The Warmth of Other Suns. That is the African-American immigrant story that has yet to be incorporated into our research. The third is Thomas Shapiro's Hidden Cost of Being an African-American, set in the same neighborhoods that Doug has described. So you want sort of fleshing out of the biomedical disability issues, those 2 books are really great. All right, enough of other people, let's get to it. Okay, so I am part of the College of Public Health, which is at the University of Georgia, Athens. Go Dogs. And here we are in Purdue. And this is the title I set up for myself many moons ago when Ken asked me. I also have to give great thanks to Ken Ferraro. I've been a fan of his forever. Newspapers have been worshiping him from afar. Never got a chance to, sit down and chat with him like I have. He's fabulous. You guys are so lucky. All right, so I can add, this is a very sort of hot button question. Does the healthcare quality contribute to disparities? Because, researchers are always focused on the disparate group, not the institutions that serve them. But I'm here to tell you that a big chunk, Title III in the Affordable Care Act, and I call it Obamacare, so everybody's on the same page. Title III is all about quality in healthcare. But the language is so dense that most normal people, and including me before I went to the Hill, would never be able to unpack it. So today what I'm going to do is try to unpack it for you. All right, that's me, Institute of Gerontology. Okay, question number 1. What is quality care? Very simple. You get what you need when you need it. Simple, timely, appropriate, correct, and only the consumer can answer this question. And right now, before the Affordable Care Act went into implementation, we had everybody answering this question except the person who received the care. I can see mystery on your faces. Okay, so here's where the healthcare access gaps are that were filled or attempt to be filled in the Affordable Care Act. Children who needed multiple procedures. Young adults leaving home. Workers in jobs whose health insurance was limited. Workers between jobs. People who are unemployed cannot get Medicaid automatically. They still have to qualify by eligibility criteria. Middle-aged entrepreneurs, if you decided today, you've been working at Purdue, Ken decided, sick of Purdue, I want to strike out on my own, and I got a business idea, I can make $1 billion. While he's trying to get to that billion, he will not be able to buy health insurance because of his age, or he wouldn't before the Affordable Care Act. The cost of premiums used to include an age calculation in it that made being over 50 a pricey proposition. It also made being a woman a pricey proposition. So if you're a woman and you want to be an entrepreneur in middle age, again, you could not buy health insurance in the private markets. And any pre-retirement adult with disabilities had trouble getting health insurance. Health insurance is how we do it in the United States. We're not a single-payer system. Not yet, anyway. We might get there. And before I went to Washington, I was a single-payer advocate. Now I know it's complicated. We live in a capitalist society, and all voices must be represented. So these are where the gaps are. Do you see any race, ethnicity in there? No. Now all of us can pull statistics that say the proportion of racial and ethnic groups that fit into these categories is more or less that, and that's where the overlap is. But is no 100% any group. And that's what makes doing healthcare policy, talking to policy people, for those of us who like reason and research and data, this is the disconnect. Questions? Comments? Yes, sir.
Did you get the sense when you were on the Hill that the absence of race in this discussion is a reluctance to consider race, or just this is the way it's always been done, so?
If I sell you a Stryker hip, does it matter if you're black or white? I don't care.
But given all the evidence that race is an important consideration, is it?
Have you seen the movie Hunger Games? Yeah. Remember the scene in Washington? For those of you who haven't seen this movie, there's a scene where the kids who have been selected from their districts have to go and show their stuff to the folks in Washington. And not that I'm saying Washington is like that, but there are people in sort of oddly colored costumes who are painted to the max, and they're sitting around eating and talking to one another, and the kids are like trying to show them how well they can shoot an arrow or all the other stuff. It's only money that cuts through that conversation, or an arrow like our heroine did in the movie. So data, that was one of my colleagues in the Health and Aging Policy Fellows program said, publishing a result from a research project is one thing. Getting people to change the way they do business is quite another matter. Doesn't get through, except when it's politically useful. I'll leave it at that. We can take that up question. Okay, so this is where the healthcare access gaps are, and this is this is why the Affordable Care Act has policies that look like it does. And what I'm going to try to do today is not spend a lot of time in the wonky weeds. I'm going to give you the bigger image of quality, and then I'll get weedy as the questions go. Is that a fair bargain? Just shake your heads so they can rattle. Yeah. All right, so here's some big ideas for today. Quality is not just a pretty word. It has very specific meaning, and for scientists, that means you can measure it. Where you live should not limit the quality of care, but it does. And I'm going to show you some evidence. You won't be surprised, or maybe you will. And consumer voices are critical for quality care. And that is another revolutionary part of the Affordable Care Act. And I will say, at this point, both Doug and Cocos made some observations, although they didn't realize they were making them at the time, that support this idea of the consumer voice. When Cocos pointed out that Mexican Americans who live in neighborhoods that are densely Mexican American seem to do better, am I getting that right? What I heard is that if you live in an area where you are understood, you have the potential for communicating better. It's a communication issue. Maybe that's one alternative. When Doug pointed out that self-reported subclinical disability was such a strong factor, that's the voice of the patient coming through your data. I did not coordinate with these guys. I'm just listening to what they say and reacting. So there's little bits of evidence from the research world that hearing what people say has important, that got through in the noise of policy development. Okay, so here's the first big idea. Quality is not a pretty word. What I'm going to show you now, and this is not for the squeamish, this is from back in 2011. Harvard, NPR, and the Robert Wood Johnson Foundation surveyed a national sample of Americans with serious illness. So these are consumers of the healthcare system. Regardless of how they got there, they've got serious illness, they've spent time in the hospital. Okay, and you can get this online. You go out and Google this. Actually, it's 2012 was even. Okay, so here's a question. The doctor or health insurance professional who was recommended to you said they're not accepting your insurance or Medicare. That's 16% of people who had a serious illness, needed a lot of care, or who had been hospitalized in the past 12 months. It's almost 20%. Okay, questions like, you did not have access to the latest technology, you were tested for something you thought was unnecessary, you had to redo a test because the doctor didn't have the earlier results. That speaks to the EMR, electronic medical record part of the Affordable Care Act. You could not get an appointment or referral to see a specialist you thought you needed, or you were given the wrong diagnosis, treatment, or test. So this is you're looking at 13 to 16% of people who are sick, seriously sick. This is not fantasy. This is the reality, the lived experience. Anybody here do qualitative studies? So you know what lived experience means. This is their lived experience. Here's another part of that survey. You saw multiple medical professionals and no one doctor understood or kept track of you. This is a very common problem in geriatrics overall. The doctor, nurse, or health professional did not treat you with dignity and respect or did not listen to your concerns. That's communication. Did not describe the choices and trade-offs of treatments. Again, 21%. You were not treated well as other persons because of your health insurance situation. That's 15%. Seriously ill people. And last but not least, because I don't want to scare you, but it gets worse. You had to wait for an appointment with a doctor longer than you thought reasonable. You had to bring the MRI, X-ray, or test with you to the doctor's office. You saw somebody who didn't have your relevant information. You had to wait it for tests. You did not get a test because your insurer wouldn't pay for it. Now, so this is the backdrop of healthcare delivery in the United States. So health disparities are just measures a gap that some groups experience, but this is the backdrop. All of us are disadvantaged in one way or another by the healthcare system that we have, and what the Affordable Care Act tries to do is fix those pieces. Questions, comments? Yes, ma'am.
You did not get the treatment or test because your insurance wouldn't pay for it. I know someone that asked for a test that they said your health insurance. He said, I will want that test anyway and I will pay for it. It's against the rules of since that person was on Medicare, it's against the Medicare rules for us to give you that.
Yeah, what she's pointing out is a friend who asked for a test. Insurance couldn't pay for it, but had volunteered to pay for it, and could not still get it. And you can argue about whether or not the test was relevant, but the consumer's voice was not heard. Okay. His money was not taken. Yes, sir. One last question, because I don't want to take it. You're going to have to speak up really loud. No. This was the patient asking for a particular test. Yes, and we're going to talk about that, yes. But right now, what I'm focused on is you as an individual within the environment of the healthcare delivery system, and regardless of what your demographic brings to the conversation. Okay, so that was big idea number one. Big idea number two. Where you live should not limit the quality of care. You would think, in all fairness, doctors are trained pretty much everywhere. We think we practice evidence-based medicine, although I could tell you the history of that is only very recent. But we have really good evidence that it does. And all you need is one quality measure, and that is mortality. Mortality rates by geography. Now, you can't see the header. It's too bad. But what you're looking at, for those of you who are geographically challenged, this is where we are in Indiana, and this is Ohio. And this is Illinois, for those of you who need a little more reference. This is the Ohio River. This is Lake Michigan. We all together? Yeah. All right. Each little square, each little colored dot represents a county. And this is data. You can go out on this website. This is the Center for Disease Control and Prevention. Wonder is this wonderful analytic tool. They have mortality files, and you can create maps. You can do all kinds of little, things with them, make charts. What I did was limited to the ages 35 to 85 plus. And I took 2 years, 2 separate years, 1979, so happens when I started medical school, and 2009. And what I asked it to do was calculate the mortality rate at the county level for these 2 states. And, take a look at them. I'll just give you like 15 seconds to marinate. Let the inner artist take in the color palette. I mean, these 2 states are almost indistinguishable. There's the state line. All right. What patterns do you see? Yes, ma'am.
Can you just tell us what a dark is? Higher mortality?
We're going to get there.
Oh, okay,
We're
I'm
getting
sorry.
there. No. She asked me, can you tell me what those colors mean? Yes. The darker the color, the higher the rates. So these are the rates for 79. And you can see the lowest ones are about 1,300 to 1,800 per 100,000, all the way up to almost, a little over 2,600 per 100,000. This is the rates, same color scheme, but now you have lower rates. The yellow group enjoys a lower range of rates. This is 30 years later. 30 years later, and you can see all color bands have enjoyed some kind of decline in mortality rates. And this is what we see. Donna Hoyert, Hoyert, is a chief mortality statistician at the NCHS, National Center for Health Statistics, published a wonderful paper in March showing that mortality rates have declined over the last 35 years. So we've done something, but what's happened, so rates decline for all categories. You can see that in the numbers. But the geographic distribution has not changed. The dark areas are still dark. The light areas are still light. There's a few, in here. Is this where we are? Where are we? Is this yellow dot? Is that us?
Just the one that's a little more rectangular right next to it. Just to the left of the
This one? No, this one.
down just a little bit. There we are.
Okay, there you are. There you are. There we are.
Yes.
And we've gotten better here. It's a college town, I would expect that. But by and large, it's still dark over here, and it's, that hasn't changed. This hasn't changed much. So the pattern of mortality, being in a high mortality geographic area, has not changed in the last 30 years. Lots has happened in the economy. These are not even the same. A few of these people are still in this age group if they still live in the area, but the geography of mortality has not changed. Don't ask me why. I'm not doing why questions today. So I tell my husband, don't ask kids why questions. They'll only make you crazy. I can tell you what, and this is the reality of 2009. And 2010, I think, is the latest data, and it doesn't look any different. Okay, so quality, if you measure it by mortality, hasn't really changed. Okay, now I experimented, some of us who like to play with data get crazy ideas. What I did was I took this data and attempted to put all the 2 years on an axis that was similar. And all I thought I was able to show is the uneven experience of decline and how county residents determines mortality. Because you can see this is the yellow group in 79, the yellow group in 2009, and the length of the bar is sort of the spread around it, and the dot is the midpoint. I don't think this tells the story any better than what we had before, but you can see that geography hasn't changed. All right, and for those of you who like big U.S. maps, okay, so this is from the Commonwealth Fund scorecard on local healthcare system performance. You're going to hear me emphasize local, because that's where you get your health care. And I'm going to emphasize consumer voice, because that's who you have to talk to if you want to make things happen. Doug's ground acquisition game has to happen at your local level. This is data for what they call hospital referral regions. You can get that kind of data on the Dartmouth Atlas website. And this was prepared, like I said, by Commonwealth Fund, who spends a lot of time scoring healthcare systems. This is all races combined. And when I worked on the Senate, unfortunately, senators will speak their mind, or their aides will, when they think no cameras are rolling. And basically they make the point, well, if you just took out all those people of color, things would be better. So here's a map with just whites. And, you know, the blue zones are still blue, and most of the dark blue areas are still dark blue. Geography matters. And hospital referral regions have variations in the quality of care if you measure it by mortality rates. And in this to do these colors, they adjusted for age, because now you're looking at all age groups combined. Questions? About the big idea? Where you live matters for the quality of care. What's happening with Nebraska? Yeah, but who wants to live there? No, I'm just teasing. Look, people say the same thing about Kansas, right?
It's healthy.
Yeah, well, or the hospital referral regions are so big, there are very few hospitals. So basically what you got in Nebraska, you got 4 regions in that area, and that's it. Utah, I'm geographically challenged. That's Nevada. Yeah, Utah, that's Utah. Okay, and they've got big referral regions. Okay, where you met? Do we all have to move to Utah to get better health care?
No, Nebraska.
Okay, Nebraska. And I will tell you, who was the senator from Nebraska that caused the big dust-up during health care reform? Anybody remember his name? No, Hatch is in Utah. Ben Nelson. Ben Nelson got a big set-aside during the construction of the Affordable Care Act that people later complained about. That's politics, not policy. Okay? But this is the reality of mortality that is defined as being amenable to health care, not just, you know, getting hit by a truck. This is mortality that might have been prevented or delayed, because as both of our prior speakers showed, mortality is the end of the road. No one gets out alive, but it's okay. It's okay. All right, so that is the end of the second big idea. Where you get your care matters for quality. Questions? You can have a question.
Well,
But you got to speak up loud so they can hear you in the back.
Two, but you said we can't ask any whys. But it was
You can ask a what. I'll think about answering it.
The Indiana-Ohio map.
You want to go back to that?
Yeah, I have a question about it. One thing that really surprised me, and I'm trying to figure out whether I'm interpreting the data wrong or what, but Lake County and Marion County look remarkably, like they're doing remarkably well, but those are also counties that have a much higher proportion, relative to the rest of the state. Basically, that is where you're going to find African Americans. I would expect the high
Heavens.
mortality, though. But instead, for those counties, it's showing some really much lower relative to a lot of counties that are almost entirely white.
Ah.
And so I'm really surprised that it would look that way. So I had a why question, given the distribution
Okay.
of ethnicity.
Okay.
Why?
Okay. So what I'll do, what she said was, there's a couple, I'll paraphrase, and you tell me if I get it
Oh, I'm sure you
right. There's a couple of places that are largely African American that seem to be doing better than places that are largely white. Oh my God, the sky is falling.
Well, how do we explain it?
Well, got to go out there and find out what those folks are doing.
Hospitals, very good hospitals.
Or,
Proximity to
you know, resilience. I mean, this is the stuff of new research. So I'm going to go back to Doug. I'm going to pick on Doug for the rest of the ground acquisition. What's happening in that county that needs to be emulated? You know, whatever's happening in that county works in Indiana. And if it works in Indiana, it works in Indiana. It may not work in Georgia, but it could work in Indiana. All healthcare is local. Local, local. Maybe you got some doctor there that everybody likes. Or maybe they've got a fountain of youth they're not sharing with the rest of us.
a higher proportion of doctors who will accept Medicaid?
Yes, you know, any number of factors about the healthcare delivery system and the people, and, you know, maybe anyway, This is the next stage, and this is how you got to pick out those high-risk areas of where to work. That's a good question. Okay, so can I go on to big idea number 3? Yes? All right. So this is my favorite. When I was writing the book, what I tried to do in every chapter was include the voice of the people that I'm writing about, the consumer, because only the consumer can tell you whether or not it was a quality experience. I mean, when's the last time you checked out of a hotel and they didn't barrage you with emails about the stay? Was it clean? Was it quiet? Did you like it? Did we serve you? And that's just a hotel. Okay, so without the consumer, there is no quality. What voices were we missing before the advent of the Affordable Care Act, which ties payment to consumer assessment? We were missing the voices of people with complex medical conditions. There was nowhere in the system for that group to feed back. I like this, I don't like that. We had no way of picking up the experience of people whose primary language was not English. Okay? And how do we know that? Because this is another graph. I love the Commonwealth Fund. I encourage you to go out to their website, download their graphs. They're wonderful. Quality is a safety issue. And this is a chart that they made up. This is complications of care, including post-op pneumonia, urinary tract infections, and blood clots in the leg. And it is the Hispanic and Asian Pacific Islanders that had the highest risk for these complications. Now, this data doesn't say that whether or not they spoke English or whatever. This kind of data, though, coupled with qualitative interviews from some of my friends who are doctors, and I know it's because some of these instances are instances where folks could not communicate that they were having pain in an inappropriate place. And it killed them. So quality is important in all kinds of ways. Are you like scared to pieces now? Well, the Affordable Care Act has some ways of fixing that and is starting to include the consumer voice. So, all healthcare is local. Are you guys ready? Buckle your seatbelts. What do patients say about West Lafayette, Indiana hospitals? All right, we're going to go. This is a website. It's called Hospital Compare. It is brought to you by CMS, and it is, let's see if this works. Ken assured me it would work till he knew what I was about to do. And we'll get this. There we are. This is a website. You can go there yourself. Click on Show Hospitals. Hopefully it works. Yeah, it's thinking about it. All right. Now, this is where we are, right? So I'm going to click on that hospital, this hospital, and that one, because you can compare up to 3. All right. Now, where's my compare now? Instant quick fix of information. All right. So we have all kinds of places, things to choose from. We have, I got this backwards, thank goodness. Patient survey results. I'm going to show you those in a second. You can get measures of timely and effective care. You can get data about readmissions and complications. Use of medical imaging. Use of medical imaging is in an analysis that was published in 2011 by Frank Lichtenberg. That is the biggest determinant of life expectancy improvement in the United States. And I can give Ken that citation if you want it. All of this stuff you can now get on these 3 hospitals in your neighborhood. Now, CMS is encouraging older adults to do this, but I would encourage anybody to do this. So, you want to see what your neighbors say about the hospitals? All right. So, this is start out by telling you about the survey. HCAHPS is what people call it. It's the Hospital Consumer Assessment of Healthcare Providers and Systems. It is a national survey. People have been working on this survey for more than 10 years. This is not new. It's been tested and tested and tested. And so you can read about the background. Click on that. It has, I'll scroll through all the questions, but it has questions like, this is what you're looking at, the percent of patients who report always to any given item. So this one says, the nurses always communicated well. At Franciscan, St. Elizabeth, 70% of patients agree with that. At IU, Arnett, 77. This is the other Franciscan. If I hadn't picked 3 institutions, you would get the national comparison. But who cares about the rest of the United States, right? You want to know what's going on in your neighborhood. This is how people rate doctors' communications. So Franciscan here's got to do a little work. Arnett's a little better. This one is the best. It's not great. You want that number to be 100%, don't you? All right, my favorite, though, is further down, because this lines up with the hotel idea. Okay. Bathroom clean. That's something you want in a hospital, right? A clean bathroom. 66% here, 72 and 75. Come on, people. We can do better than that. And quiet at night. Quiet at night. When you cannot heal if you cannot sleep. That is when your physiology kicks in. All the hormones for growth, development, repair. You cannot heal if you do not sleep. These hospitals, as far as I'm concerned, have failed the quiet outside your room. You wouldn't stay in a hotel. If I've been in hotels where I got awakened at 3 in the morning because the room next to me's alarm clock went off, and it was really, really loud. So I called the front desk, and they turned it off. Quiet at night is one of those quality measures, really, really important. I think the other quality measure is recommended to your friends. You've seen that question. You know how it works. 61, 75, 76. Not that you would recommend your friends go to the hospital, because you know it's not a good situation, but, you know, let's say you're having a baby. Oh, I'd go to this hospital because they treated me like a queen when I was in labor. So these are ways of getting at what people have, what your neighbors are saying about your local health care. Now, if any of you have access to the hospital board or someone in charge, you can talk about this. This is a place where community advocates can start that dialogue. Questions? Are you surprised? Have you ever seen this?
What is that website again?
It's, hang on, let me pull it down so you can have it. Oh, they're going to be hits tonight. Okay, this is Hospital Compare, one word, .hhs.gov. Yes, ma'am.
I mean, my son has a chronic illness, so I filled this out, I feel like, 1,000,000 times for his hospital.
And what she's saying here. Say it loud.
I have a son with a chronic illness, and so I have filled this out a lot of times for his hospital. And it's huge, though. Like, I feel like there's an awful lot of questions, and, you know, I have actually admittedly thrown it away lots of times, too. And then it comes in the mail again.
Yes.
And I was just wondering,
They're relentless.
do we really get a lot of people filling it out? Since I mean, I've seen it as a mother going, and the whole bunch of I don't knows, too.
Right.
You know.
No, if you go, that's what. So she's asking the research thing. How many people? What's the response rate on this survey? You can look at that. So right now, the last time I looked, it's about a 30 to 40% response rate. Because after all, you're sick. Or whoever's answering it for you is tired from taking care of your sick person. So the response rates are not great, but what gets to you is the fact that they're stable over time. And not doing a good job affects their payment. So this is not just a feel-good kind of measure. This is tied in the Affordable Care Act to payment for services rendered. I want to show you one other thing. This is another scary part of the survey. This is not the consumer voice. There are other more objective measures of how they work. This is a rate of readmission for heart attack, death rate for heart attack, readmission heart failure, death rate heart failure, readmission pneumonia, death rate pneumonia. Part of what the Affordable, okay, thank you. Part of what the Affordable Care Act does is it encourages hospitals to work on the things that bring people in after they've been discharged for the first time for a diagnosis is usually something that was unresolved related to the first event. So this is, and right now we don't have any, other than this. This is one of the other things that the Affordable Care Act has now introduced into how we pay for health care. All right. Now, so I'm just going to conclude by saying quality care. Do you get what you need when you need it? It has to be timely, appropriate, it has to be correct, and only you can answer that question. And that's how the Affordable Care Act is constructed. So I'm going to stop talking because I got a stop talking sign. And I'm going to answer some questions because I know you got them. Thank you. All right. Yes, sir. Now wait to the microphone. Wait to the microphone.
There was an article published either in Newsweek or Time this past week.
That bastion of medical health care information?
Well, and it was, I believe it said that in New York State, when they published the death rates in the hospitals dropped significantly. That therefore, they were proposing that death rates in hospitals should be made public.
Okay, so they will be made public through this website. So your point is make it public. Yes, that's a good point. Okay, there's a hand in the back. Dr. Sands is going to weigh in. Okay. No, use the microphone. We don't want you straining that voice, mellifluous tones.
I teach graduate nursing students. A nursing student came to me and she says, look, says my satisfaction rating is at 82% for my division and it's 83% for the hospital next door and I'm going to get fired. And I tried to explain to her about standard errors. Do we need to educate the public about the meaning of a 72 versus a 73% or a 74 versus a 76?
I don't know. I think all of those are crappy. I think the first thing we have to educate the public about is that they have an input into the process. I mean, I think we've all, myself included, have been trained to believe that we cannot, question what's happening to us. And this says, no, quality involves a dialogue. And so, most people are enumerate anyway. No, I don't mean that. But small bits, I don't think that's that important. But that's a good point that you raised. Come on, yes.
But I think it does raise a question on how this information is given to the general public. So, for example, mortality rates, they're going to be affected by the severity that the patients being...
All of that's been adjusted for. In the data that you see, when you look at that, okay, what she's raising, this is what a hospital, you work for the hospital, right? Hospital administrators had, when they started this quality, actually, back, let me give you a little history story. Elizabeth McGuinn and her colleagues at RAND started looking at quality measures back in the 80s. They looked at mortality rates by hospitals, complications, and the first pushback they got was, our people are sicker than everybody else. You know, and so that began a long dance between, like, what's your public charity hospital here? Which one? Okay, so St. Elizabeth, she tells me, is your public charity, take all comers hospital. Is that general consensus in the room? Okay. Okay, so on some of those measures, St. East did a better job. It really is very important that the local institution respond to local people needs. You got to push them on this. I mean, you'll never get, you can't just say, well, those people, we can't take care of those people because those people just, you got to figure out how to get people what they need and help them help themselves. Because I think people want to. I mean, look at everything we've seen says it. Yes, sir.
So do you have a sense of what the doctor's perception of this is now that I guess there's a push for the people getting the care to have a voice? Are they in favor of that or against that?
Well, it depends on who you are. There are, physicians are people, you know. We went to medical school. We started out being people. We got some specialized knowledge. We came out of medical school. We're still people. And some of us really like this, like me. Some people are like, I don't know what this means. They're like the nurses. You know, am I going to lose my job? Am I not going to be able to treat patients? It's all over the map. There were, I'll tell you a little story from the Senate Finance Committee. We had physician groups visiting us saying, we don't want this. And we had other physician groups saying, bring it, because we like that back and forth. So it's all over the map.
I guess I was kind of thinking about it, you know, at the end of the semester when I get my teaching evaluations back. You know,
Well, see, yes. Hey, been there, done that. And, you know, some semesters they spank you hard, right?
Exactly.
Okay, and what happens, you put those evaluations off to the side, you cool off. You come back, you read them again. Sometimes they're right. You know, I have students have said, you just beat on us all semester long. They're absolutely right. And so I had to adjust my teaching methods if I wanted to be effective. Now, if I didn't care, you know, I'd just go, well, they're too stupid to understand what I'm trying to tell them. Fortunately, my job wasn't on the line, and I already had tenure. But it's going to be that kind of process. Definitely going to be that kind of process. Other comments, questions? You guys are so good. Thank you for your attention.
My sense is that if Dr. Miles' influence extends, then maybe the hospital compare won't do different from the national average, but might do different from a state average or a regional average. Maybe there's a thought. Hey, it's been a good day, and I want to thank each of our presenters. They were good about staying on time. I appreciate the graduate student helpers throughout the day, and I also want to thank our co-sponsors. It's been a great series of lectures, stimulating, but also somber in other respects, because it points to some disparities that are stubborn in our society. And that's our task, is to figure out how to address those so that everyone can age optimally. Before we head to our poster session, I have two announcements. And the first, I'm going to ask Melissa Franks if she'll come up. Would you come up, Melissa?
I get to make a commercial announcement for next year's symposium. We will be hosting big idea number 4. Quality matters, but so do the people in your lives. We'll be looking at social influences on health lifestyle choices, and our speakers will be Deborah Carr from Rutgers, Karen Hooker from Oregon State University, and Alex Zatra from Arizona State University, and we'll be continuing our discussion on health behaviors and successful aging.
Great, thank you very much. And that's really good news because that's another co-sponsorship where we'll be working with the Center for Families next year. I also want to thank Ann Howe because she helped with a million details. Where's Ann? There she is. Thank you, Ann. She is so special to each one of us. The other announcement I want to make is that the Center on Aging and Life course each year gives an award. And the purpose of the award rotates from year to year across research, teaching, and service. And as some of you may recall, Dr. Laura Sands was honored last year as our outstanding professor of the Center on Aging and the Life course. This year, the award is designated for engagement, and the committee considered many excellent people and organizations that advance our service mission, but one team rose to the top. The people we honor today are both faculty members in the Department of Health and Kinesiology, and actually going back in the archive, I see that that department won this award previously, too. So that's pretty special. And it's my pleasure to confer the Exceptional Engagement Award on Drs. Jeffrey Haddad and Dr. Shirley Reitdyke. Would you please come forward? Dr. Haddad came to us from the University of Massachusetts and Dr. Reitdyke from the University of Waterloo. Each has excelled at Purdue together. They have helped put Purdue on the map for the science of aging, balance, and biomechanics. Today, however, we honor their exemplary engagement. As many of you know, the Center on Aging and Life course partnered with a local continuing care retirement community called University Place in 2009 to develop an intervention research unit. And we have had several projects out there, but this has been the gem of the projects because it's still going in its 4th year. All of those projects did a great thing, but what this project did, which was truly exemplary, was the masterful blending of research and teaching and engagement. Special. Jeff and Shirley joined forces in what is known as the Balance Project, which seeks to better understand balance and the biomechanics of, to prevent falls among older people, I want to quote from a couple of the residents as well as from some of the students involved in this project. Some of the residents made statements such as, I love getting to work with these young people. I don't know if they were talking about you two or the students. And literally, they made comments such as, quote, they helped me with my balance. It was fun. The students in the class said things like, this class was tough. However, I learned so much from this class that it will translate into my future career. And another one, and this is pretty impressive in a university that's well renowned for chemistry, it said, this is by far the best lab I have ever taken at Purdue. Jeff and Shirley, thank you for your exceptional engagement work. You two have been models for both of us. I'm going to ask Dr. Tim Gavin to come forward. He's head of the department, and I'm going to let him brag on you as well.
Well, I was already told I'm here. Dean Lash wanted to be here but was unable to make it, but I'm expressing her wishes here. I was told to make my comments brief, and actually the word in front of it was very. I will do so. I'm very proud to have these two members in our department, and I think, as Dr. Ferraro said, what is most special about the project that they work on is they combine the three issues that we're interested here at Purdue. They're engaged in our community, and they make a difference in the lives of the people we touch. They're engaged and do excellent learning opportunities with our students. As you heard from the quotes, I'm sure our students find them very challenging. I do as I work with them, but they get engaged and they get an opportunity to see something that was very difficult at a large research institution. They get to see practical application of what they learn and how it makes a difference in people's lives. And finally, they bring back to their colleagues around the world their findings, talking about how they engage with their community, how they work with our students, and how they change the lives in ways in which we can improve the quality of life of our aging population. So with those three things, I think they do exactly what we always strive to do, both here at this university and in academics, and it's with great pride that Health and Kinesiology has for your endeavors. Thank you so much.
So I wanted to share how this sort of project came about. Jeff and I started doing research, and because we were training older adults, we couldn't have our graduate students out at University Place for 20 hours a week, and we couldn't be out there as well, so we recruited undergrads to do the training for us. So we got senior undergraduates to come out and do the training and work with the older adults, and they also were involved in the assessments. And we got to watch those relationships develop over the course of the training. And what I found so fascinating afterwards was we've had undergraduates work in our research labs before, and we'll get the email 4 months later saying, "Hi, Dr. Riedek, how are you doing? Hope things are going well. Can you write me a reference letter?" And but after we started this research with the training, students wrote and said, how did the assessments come out? How is this resident doing? How is that resident doing? So we really wanted to capitalize on that and keep the momentum going from that.
And I guess all I would add is Shirley and I would both really like to thank Dr. Ferraro and the people at UP for giving us space and working to establish the collaboration in the first spot, because it really has been a great opportunity for us, the residents and the students.
At the back of the room, there are several posters that have been displayed, and in your registration packet is an abstract of those posters, and if you want to catch some notes. And I believe we'll be receiving some refreshments in just a few moments. So if you would like to make your way to the back, you can follow up questions with our speakers, enjoy the posters and some refreshments. Thank you very much.